Hello and welcome, everyone. Thank you for joining us for another session of the Neuro-Ophthalmology webinar, um, where we dive deep into trends to share insights and connect with professionals from around the world. I'm Dr. Marian Roque Carabello, your host for today, together with my co-host, Dr. Griselle Tandy, and we're thrilled to have you back. Or if it's your first time with us, a special welcome to you. We've got a fantastic session lined up today on idiopathic intracranial hypertension guidelines and current trends, packed with practical takeaways and expert perspectives you can put to work right away. As always, we leave time for a Q&A at the end, and so feel free to drop your questions in the chat as we go. And now, may I call on Dr. Karen Reyes, previous president of the Neuro-Ophthalmology Society of the Philippines, to give the opening remarks.
Good afternoon. Thank you for joining us today for the third of our four-part webinar series hosted by the Neuro-Ophthalmology Society of the Philippines. As we celebrate our 25th year anniversary, Gian, where is my opening speech? Ano nangyari? Um, Okay, I will continue. Okay, thank you for joining us today again for the third of our four-part webinar series hosted by the Neuro-Ophthalmology Society of the Philippines as we celebrate our 25th year anniversary. Spearheaded by the NOSP President, Dr. Franz Marie Cruz, and Webinar Director, Dr. Marian Carabello. We're thrilled to see so many of our trainees, colleagues, and friends participating in this online event. We are honored to have with us today Dr. Susan Mollan, a consultant neuro-ophthalmologist at University Hospital Birmingham, UK. Her insights today will provide us with a fresh perspective on the latest developments, management strategies for idiopathic intracranial hypertension. As we embark on this knowledge-enriching activity, we wish the NOSP continued success in its mission to advance the field of neuro-ophthalmology, and we look forward to more activities in the next 25 years. Let us now continue on with today's webinar. Congratulations, NOSP, and especially to the entire 25th anniversary team. Thank you.
Thank you, Dr. Karen. Now, let me introduce our guest speaker for today. Professor Susan Mollan has established international reputation in neuro-ophthalmology. She is an honorary professor at the University of Birmingham. She is the first international member of the board of the North American Neuro-Ophthalmology Society and a research theme chair for the European Neuro-Ophthalmology Society. She has been instrumental to this stable running of the British Isles Neuro-Ophthalmology Club and the UK Neuro-Ophthalmology Society. She is a Royal College of Ophthalmologists International Senior Examiner who sets exams, supports candidates and examiners, and assures examination standards across the world. Her research citizenship includes being an associate editor at Eye Open Springer, section editor in Neuro-Ophthalmology for Eye Springer, sub-editor for original contributions at Journal of Neuro-Ophthalmology Lippincott, and a board member of the Neuro-Ophthalmology journal Taylor and Francis. Her impactful publications include 200 peer-reviewed articles and 13 book chapters. She reported the first randomized controlled trial into weight loss methods in idiopathic intracranial hypertension in 2021. She actively works to provide and pragmatic guidelines for clinicians, and these include IIH consensus guidelines back in 2018, EULAR GCA guidelines in 2019, British Society of Rheumatology GCA guidelines in 2020, the European Headache Federation GCA guidelines in 2020, the guidelines of the International Headache Society for controlled clinical trials in IIH in 2024. She's currently part of the European Alliance of Association for Rheumatology Task Force for Polymyalgia Rheumatica and Large Vessel Vasculitis in 2025 guidelines and a cerebrospinal fluid section panel member for the European Association of Neurological Surgeons. Everyone, let us welcome all the way from England, Professor Susan Mollan.
Thank you so much for that wonderful introduction. And I'm really excited to be here as part of your celebration of 25 years of the Neuro-Ophthalmology Society of the Philippines. And today I'm going to be bringing you sort of highlights from those guidelines, but recognizing that some people may not see as much idiopathic intracranial hypertension as we do here in Birmingham. I do have some disclosures that relate to IIH, and Invex Therapeutics there is bolded because I did some consulting for them when we were looking at a novel GLP-1 receptor agonist repurposing and also Heidelberg Engineering for not only delivery of education, but they've also loaned me equipment for further research. So to really start to set the scene is IIH, or benign intracranial hypertension, has been recognized for over 150 years. But with the advent of the direct ophthalmoscope, but also lumbar puncture, this condition really started to be phenotyped by our sort of forefathers in neurology and neurosurgery. And this is just one of the excerpts about serous meningitis, which was one of the many names attributed to IIH. It's obvious from the review of the literature that these patients can recover spontaneously, or at least with conservative treatment. However, in many instances, it's not clear whether the impairment of vision occurred in patients who were treated expectantly or conservatively. And I think even that suggests that the link with visual loss it can be challenging, particularly for our neurology, neurosurgery colleagues who may not have clear access to ophthalmology. And we'll talk about that as we go through these guidelines. So what I really wanted to bring to you today was that we know so much more in the last sort of 20 years. So we know that IIH is a condition of raised intracranial pressure that causes papilledema, but also really debilitating headaches. We're starting to understand that IIH is a systemic metabolic disease over and above which is conferred by living with obesity alone. Our patients have increased cardiovascular risk even when we control for living with obesity. So this is different and a unique condition that actually we're growing up with. So although it's a rare condition, many, many more people are getting this condition. And we know that as they move into their 50s and their 60s, they may be at higher risk of a heart attack or stroke. We also have maternal health issues with these patients. They have impaired fertility, gestational diabetes, and are at risk of preeclampsia. And this isn't something that we've really known about IIH, and how now we have to spend a lot of time talking to our obstetric colleagues, particularly about IIH and not just living with obesity. Our patients also, 1 in 3, have polycystic ovarian syndrome. Nearly 40% have obstructive sleep apnea that actually needs treatment. And a large proportion of our patients have a burden of mental health. And although I've highlighted anxiety and depression here, we know that they have behavioral eating disorders as well. And that's more work will be published on that soon. But for us as ophthalmologists, and if there's any neurologists in the audience, first and foremost, we need to safeguard the vision. We really need to think about treating headache. And I know as a group of ophthalmologists, you may not be thinking about treating headache, but hopefully I'll show you some things in the latter part of this talk that we can all simply do, even if we're not trained in headache. And also what we have to do is address the underlying disease for our patients. So we're going to start off with papilledema, because papilledema is the sort of entryway of the pathway for most of our patients. So papilledema is a clinical sign. Bilateral optic disc swelling is secondary to raised intracranial pressure. And you can't just look at a patient and say, oh, they have IIH. You have to go through the investigational pathway, because there are many other things that can cause papilledema, some of which, although incredibly rare, do cause problems such as tumours. So we identify the papilledema, and then we think about the typical history that our patients may have. The issue is they're not unique to IIH. So they have headache, neck pain, they can have visual obscuration and pulsatile tinnitus. There are some other rarer things that at the start of the condition, patients may not realize, although their family members might, such as cognitive disturbances. But the really annoying thing is when we think about raised ICP headache, the textbooks say headache is exacerbated by bending, coughing, straining. They come early in the morning and it worsens with physical activity. But when Rigmor Jensen's group had a look at IIH patients and also migraineurs, you can see there with the controls, they too get headache that is exacerbated by bending, coughing, straining, etc. So that doesn't help us so much rule in or rule out raised ICP just from the history. And again, the same is true of visual exacerbation. So I didn't realize that migraineur controls also report blurred vision, pulsatile tinnitus, and visual obscurations, albeit not at the same frequency, but it shows you that although we need to take the history carefully, it doesn't rule in or rule out raised ICP. And there's some myths that we find in clinic. If they're completely asymptomatic, this is pseudo swelling, maybe it's drusen or otherwise, but actually, no, that's not the case. And again, if the headache is migraine-like, therefore it's not raised ICP. And in my clinic, 10% of patients are completely asymptomatic when I see them, and 50% of my patients have migraine-like headaches. So again, these sort of history points, we need to note them, but they don't help us point in a direction. When we have papilledema, it's really important to think about the past medical history. We think about other diseases that may cause raised intracranial pressure. Drug-induced IIH is really important as well, because often we forget to ask about medicines such as isotretinoin, vitamin A, analogues, fluoroquinolones, tetracyclines. And no history is complete without a social history and a family history. And also we must think about other substances such as nitrous oxide, which has been popularized more recently, that can cause raised ICP. And the thing about drug-induced IIH is that actually, if you stop the medicine, often the intracranial pressure comes down rapidly, which is a good way to be able to treat those patients, and they don't need to go down certain other pathways. So with any drugs, there are some drugs that are more strongly associated and some drugs that are more weakly associated. And I just want to touch on oral contraceptives, because often when I talk to my colleagues around the country, they do recommend a change to somebody's oral contraception when they have a diagnosis of IIH. And actually the evidence is pretty weak for this. So what I say is if there's a temporal relationship, i.e. they started the oral contraceptive 6 weeks ago and then got their headaches and then came in with papilledema, that might give you the temporal association that you may want to consider a change to the contraceptive. Otherwise, for the majority of people, it's absolutely fine for them to stay on their contraception. So after history, we think about the eye examination. And, you know, as a group of ophthalmologists, we all know it's actually quite difficult sometimes, particularly at the lower ends of papilledema, to be absolutely certain it's papilledema. We need to exclude other causes such as optic nerve head drusen, tilted myopic discs, small hypermetropic discs, and the list goes on. And it's important that at the start we establish whether it's papilledema or pseudopapilledema, because then the investigational pathway gets a bit more invasive. I always impress upon people the importance of formal visual fields. And here I just wanted to kind of highlight the visual fields. You can get any visual field defect with papilledema, but looking at those mean deviations between, you know, minus 1.7 there down to -6, if we think about starting to treat these patients where typically in a medically treated cohort, we would say actually up to -7 is a medically treated cohort. I'm not so sure I would be happy with the visual field loss in D there with the enlarged blind spot and that scotoma there, whether that for me in conjunction with looking at the optic nerve really sits in the medically treated group. but there's going to be more about that later. So after the eye examination, we think about a neurological examination in terms of looking for cranial nerve palsy, particularly thinking about a sixth nerve palsy or bilateral sixth nerve palsy. I have to say, in my adult practice, double vision isn't often a presenting complaint of raised ICP. And when I speak to my pediatric colleagues, I think it's more common for them to have double vision than the adult patients. Then we think about taking a blood pressure because we want to exclude malignant hypertension. And if somebody has malignant hypertension, they come off the papilledema pathway and you follow your local hospital protocol to get those patients signposted immediately to the medical doctors to think about causes of why they have malignant hypertension and treatment. The next thing is thinking about doing a full blood count and electrolytes early. And the reason to do a full blood count, as highlighted on the slide here, is 10% of our patients have iron deficiency anemia. IIH is common amongst women of childbearing age, so is iron deficiency anemia. However, if you manage to reverse the anemia, often the raised ICP settles very nicely without other treatment. So I think it's really important at this point to check the full blood count. It's not that you're not going to continue on the investigational pathway for those with anemia, but it means that you have a way of treating things. We then think about neuroimaging. And neuroimaging, it doesn't matter what it is, whether it's CT or MRI, but as long as you get venography in the same sitting. And that's important because you need to exclude a venous sinus thrombosis, because that's what's going to cause significant morbidity and for some even mortality. So getting a good read on the venography is critically important. Now, there are some neuroimaging features of raised intracranial pressure, but what I would say is they're not pathognomonic, and a lot of work has been done at the minute. There's lots of papers flying around talking about numbers of neuroimaging features that would rule in or rule out raised ICP. And the issue with this is we don't really know enough about when you have an established partially empty cella, it doesn't disappear like some of the other features. So it may not be telling us the picture of what is going on now. It might tell us a picture of what possibly has gone on. And I think with the advent of MRI ICP measurement, which is new techniques to gauge what the intracranial pressure is doing at the time of specific MRI protocols, I think in the future we will see a lot more of that rather than on the sort of static image features that are shown on the slides here. Then we ask our really wonderful either medical colleagues or neurology colleagues to think about a lumbar puncture. And it's really important as ophthalmologists that we don't disengage in that conversation. So the conversation that I would have is I would like to have an opening pressure and I would like to have the contents sent to exclude other things such as meningitis. And I think that's really important because you want that feedback back. You want the contents to be sent off. And the little thermometer on this part of the slide shows that actually we don't know where the cutoff is. So previously it was 20 centimeters of CSF, that went up to 25 centimeters of CSF with the new diagnostic criteria. But for most of us, there's a bit of a gray zone. So if somebody has a CSF opening pressure of 26, it doesn't necessarily mean that it rules in the disease. The opening pressure has to be taken in context of the whole patient, because when we do lumbar puncture and the patient is crunched up on the side, they can artificially raise their lumbar puncture opening pressure by flexing the neck and the intensity if they're sort of holding and squeezing their body. It is a single measurement, and we know that there's this wide variation. And it just goes without saying that if the lumbar puncture doesn't fit the clinical picture, you interpret it with caution. And sometimes I don't necessarily repeat the opening pressure, and I use words such as definite IIH, probable IIH, because lumbar puncture can be quite significantly sensitive for our patients. It's not a very pleasant investigation. There is a little bit of a vogue in the literature to say, well, you know, they've got papilledema, they don't have a venous sinus thrombosis. Do we really need to do the lumbar puncture? And I do think it's important because there are other things that can cause the clinical picture, such as MOAG disease can cause really, really horrible swelling of the nerves. And it's important that you look for pleocytosis and increase cell count. But there's also some other rarer causes. So I do think it's important still to get a lumbar puncture and send the contents off. Then when we think about moving through to management, we've got to think about the extent of papilledema. So that's where ophthalmology is really at the forefront. We need to tell our colleagues what's happening with the visual field. Not are there any changes with color vision or pupils? And so the symptoms that I tend to get worried about is increased visual obscurations. That worries me. Not everybody gets TVOs, but if they do and they're increasing, that's a problem. And again, the same thing with increased pulsatile tinnitus. A lot of our patients have pulsatile tinnitus, but there's an increase in the noise, or it goes from one ear to then both ears. I'm thinking that the ICP is continuing to climb. I get very worried about color vision. I definitely get worried if there's a relative afferent pupillary defect, because typically this is a bilateral disease. And actually, if you get an RAPD, there's often really a lot of damage going on. We think about visual field deterioration and then very, very late visual acuity loss if fluid is slipping from the nerve towards the fovea. So we need to protect the vision. And these are the management principles from the guideline. We know that the majority of people fall into that benign category where they have the condition, but they're probably at low risk of visual loss. And we have a few patients that are high risk of rapid visual loss. And there's a couple of things that we can do to help treat intracranial pressure. So we've got some medicines that I'm going to talk about that target CSF production. And obviously for those high-risk patients, we have the options of drainage of CSF, like a shunt, or we're now thinking in terms of stenting, targeting the venous outflow. What I would say about the intervention side of IIH is there are no randomized controlled trials to date. We are working on one here in the UK. There's also one going on in Paris at the minute, but unfortunately the one out of the Barrow Institute in the States closed, and it shows how difficult it is to run surgical trials for IIH in a rare disease at the rare end of the spectrum. So who requires sight-saving surgery? About 7% of our cases in the UK. But the good news is you see that percentage falling. And that percentage falling is helpful because we know we're having an increased prevalence of this disease, but maybe we're managing it better and doing less surgery. And this is similar to what's happening in North America. And I just put up that chart. It seems in the literature that everybody's stenting, but actually when we look at our surgeries, shunt remains the most common surgery for those that require it. So I'm going to give us a bit of a rest and go to a case. So this is a 30-year-old woman referred by her optician to eye casualty. She starts within the last 9 days to get intermittent headaches and blurred vision. She actually has a sharp pain in her neck. And often if you ask my patients, the pain does seem to come from the neck region, and she has spasms in her face. She has no pulsatile tinnitus, and it doesn't get any TVOs on bending forward, but she does have bilateral disc swelling. The rest of her sort of systemic review doesn't reveal anything that we'd be concerned about. So she's referred to the acute medical unit, and they've followed the pathway immaculately. So the blood pressure is recorded as normal. There's no anemia. The CT is done, notes a partially empty cella, and there's particularly no venous sinus thrombosis on venography. The lumbar puncture is done, and there's no doubt that this is raised at 38, so it's not sitting on a borderline, and the constitutes are normal. Now, as what happens when a patient moves from one specialist to another specialist, sometimes there can be a little bit of gap in care. So this has been absolutely exemplary, but actually on discharge, no treatment has been given. And the headaches improve for a few days after LP. That doesn't mean an awful lot because headache can improve in migraineurs that have LP as well. But hey, her vision isn't normal. So 612 isn't a normal vision. So I'm already worried about this patient. 6 weeks later, she comes to the general ophthalmology clinic and there are new transient visual obscuration and the vision isn't good at 6:24. The colour vision is holding out, but the visual fields show there's an enlarged blind spot on the right and they're noted to have grade 3 papilledema. And they started on a really low dose of acetazolamide. So 250 BD is very small and we're going to talk about the IHTT shortly. So this is what I'm worried about. New TVOs, and a very, very low dose of acetazolamide. She comes a week later to the accident and emergency room because she's got worsening of headache. And they don't assess the eyes because they're not really that confident in looking at the eyes. And they kind of think, well, you know what, she was seen a week ago by the ophthalmologist and the ophthalmologist thought it was fine. She gets a CT head, which isn't really going to be diagnostic. And the notes are written, please, can we refer to a consultant? So on reading those, we pull this patient into our clinic and we're very worried because the vision's 6:12 with no pinhole, and that's just not normal. There's a right relative afferent-papillary defect and her papilledema is graded as grade 4 in the right eye, now noting hemorrhages and cotton wool spots. And so this is really worrying. And what I wanted to run through is one of the OCTs that we would see in a typical patient who has sight-threatening disease. So immediately, you know, the disc is elevated, there's subretinal fluid there, there's intraretinal fluid, there's lots of hyperreflective dots in between the fluid. There's a couple of other features as well. So the blood vessels are thick and chunky and hyperreflective, and they have a little bit of an umbra around them. And even on the ENFAS image, you can see that fluid tracking towards the fovea. This person really needs intervention because they're going to lose their sight because you won't recover the vision back to normal. So what we do, and we're fortunate in our unit because we have neurosurgery in-house, she gets the same day shunt to save vision. Now, if I had to wait because my neurosurgeon that is a specialist in CSF disorders isn't there, often we would place a lumbar drain until we get the right surgeon to be able to help us with the treatment. So high risk to vision, like this patient, there are no randomized controlled trials to guide treatment. We hope that will change in the future, particularly as stenting has become more popularized, and it looks as though stenting and doing a shunt reduces the intracranial pressure equally. But what about all those other patients? So we've got some patients who have very minimal signs of papilledema, and I might suggest that you may not treat those with very little change on the visual field in terms of the ICP. I'm not talking about the underlying metabolic disease, which we'll get to shortly. But for some patients, they can have a lumbar puncture, have lifestyle advice, and actually don't need to go on acetazolamide. And then we have these patients in between, a more moderate risk to vision and the perimetric mean deviation within the sort of trial inclusion criteria for the IIH treatment trial. And those patients, we need to think about what dose of acetazolamide. So in the IIHTT, they used up to 4 grams of acetazolamide in a daily divided dose. Now, a lot of the patients experienced side effects, but it was clearly effective at reducing intracranial pressure, but also protecting the visual field. Now, these infographics will be, they're available online at iJournal. So there's a collection of randomized controlled trials, not only for neuro-ophthalmology, but also glaucoma and medical retina. And they're a great resource, particularly if you're doing exams and you want to quickly look at studies. And so the IHTT randomized patients to a weight loss intervention as well as acetazolamide. And the primary outcome at 6 months favored the use of acetazolamide. Now, there were many other things that they looked at, and there was an awful lot more weight lost in the intervention group because acetazolamide tends to make our patients feel nauseated and puts them off food and they lose their appetite. And through a mediation analysis, they were able to rule out the significant weight loss in the intervention group. So this is where we get our clinical practice criteria in terms of those patients that may not have had a problem with the visual field may not need acetazolamide, but those that have some change on the visual field, it's important to think about acetazolamide. So what we did in Birmingham, because we were quite interested in the medicines, because acetazolamide, I think, was approved in the 1950s. So it's quite an old medication. And some of the studies that looked at raised intracranial pressure for, say, frusemide were done in the 70s and were done in rabbits with very large doses of frusemide. And we really wanted to get a handle on, when we use these medicines in our women, how does it change their intracranial pressure? So we had 14 ladies that had telemetric ICP monitors placed for one of our trials. And as part of this sort of group of studies that we were doing, we decided that we'd be able to circle them through lots of medications that people have used for IIH and also raised ICP. So patients were randomized to start any of these medicines, and they would have the treatment for 2 weeks. It wasn't optimal doses, but we got them up onto fairly high doses of each of the medicines. And then we were able to check their intracranial pressure non-invasively with these monitors that are highly accurate. And so following 2 weeks of treatment, there was a fall in ICP recorded with all medicines apart from amelioride. And when you look at those reductions, and this is millimeters of mercury, actually they turned out to be very similar. Acetazolamide was very similar to frusemide, spironolactone, and topiramate. And we found that no drug was better than another. Now, this is a very small study, but I think it's helpful for us to note that sometimes we think, actually, if somebody doesn't tolerate acetazolamide, what are we going to do next? Well, actually, we have other medicines such as frusemide and spironolactone to use. I would caution topiramate. We've had a Medicines Health regulatory alert on topiramate about using topiramate in young women of childbearing age because of the unwanted side effects of the unborn baby. And so if you're going to use topiramate, it's a careful conversation with the patient, and we have to think about at least 2 forms of effective contraception. So moving to managing the underlying cause. And this is the challenge. This is quite a busy infographic here, but the references to the side there, this was drawn by Dr. Lowe, one of our neurology doctors, just trying to think about IIH. So we know that it's a CSF production problem. We know that that's driven by metabolism, either in the steroid pathways, but probably more predominantly in the androgen pathways. And we're thinking about testosterone rather than the estrogens driving fluid secretion. But we also have the other side of it, of CSF clearance. So we have to think about this balance of how we're going to target treatment for our patients. But more simply, we know that majority of our patients have modest weight gain at the start of their disease. And we know that weight loss has been reported to be an effective strategy. Now, in the past, with the rice diet, the very low calorie diet, we were looking at weight loss between 3 and 5%. When we did our IIH weight trial, which was bariatric surgery, evaluating against a Weight Watchers intervention, to actually normalize the ICP, to bring it below 25, they had to have a reduction of 24% of their body weight. Now, I'm not saying everybody needs to normalize their ICP. I think it could be accepted that we don't need to get everybody below that normal mark, but it shows you the extent of weight loss that may be required. And actually, you can't do that just with the diet alone. The majority of people, that's just not effective for a long-term chronic condition such as living with obesity. And so on the graph there, you see the percentage weight change that we had in our patients with bariatric surgery versus a dietary intervention. And this is really just a nod to some of the data that we got out of the weight trial to really show how unique IIH is compared to just living with obesity. So we had obese controls that we were able to recruit that also had bariatric surgery for their weight loss. And we were able to compare their abdominal fat cells compared to IIH. And what we find with the IH patients, which was really interesting, was not only are they insulin resistant and they have hyperleptinemia, but actually they were transcriptomially primed for more weight gain. So our patients, not only when they try weight loss, the actual fat cells themselves is primed for more weight gain. And there's a lot more we need to understand about that. So when we think of different ways of losing weight, from diets all the way through to bariatric surgery, you can really see that you have to do something quite significant to have sustained weight loss. Now, this just runs through the infographic. And again, you can find these nice infographics in the eye collection. I'll just move through that. But I guess some of you are sitting there thinking, well, now things have changed quite a lot in the weight management literature with the advent of GLP-1 receptor agonists. And of course they have. The STEP trials and the SUSTAIN trials have really showed how fantastic GLP-1 receptor agonists are at weight reduction. The issue really is about keeping the weight off. So when you stop the GLP-1 receptor agonist, if you don't have a significant lifestyle change, you will find that those patients regain a significant amount of weight. And that could be challenging for our patients with IIH, because you don't want significant relapses in a sort of dramatic way. There are some studies now that have reported use of GLP-1 receptor agonists for weight loss. They show that the patients definitely lose more weight, they have less headache, they don't need as much acetazolamide, and they can tolerate the side effects as compared to, say, acetazolamide alone. So I think we're going to see a lot more of these studies coming out about how beneficial GLP-1 receptor agonist for weight loss in IIH is. I just wanted to highlight were the work that we were doing in Birmingham using exenatide, which is a short-acting GLP-1 receptor agonist. And what we wanted to do here was not demonstrate weight loss, but demonstrate the fact that it can actually affect fluid secretion at the choroid plexus. So in our women with these beautiful, highly accurate telemetric monitors, we randomized patients to either placebo or exenatide. And we looked really early on and out at 12 weeks. And if you remember back to the slides on moving around the drugs, actually with exenatide, we had fantastic reduction in intracranial pressure, not only at 2.5 hours, 24 hours, but all the way out to 12 weeks. And it's important to note at 12 weeks, our patients didn't have significant weight loss, and we hadn't advised them to use this GLP-1 alongside a lifestyle intervention. So we inferred from this that this short-acting GLP-1 could have direct action on the choroid plexus. So really, GLP-1 receptor agonists, we don't know whether this is a class action from the family of drugs. We think it's probably very specific GLP-1s that can modulate CSF secretion. So in the last bit of the talk, I want to talk about headache, because once our patients have minimal papilledema or the papilledema is melting away, they come to our offices and we're happy because we go, the papilledema is gone, but they're not so happy because they've still got horrible headaches. And as ophthalmologists, we don't really have the tools to be able to manage headache. So I hope I'm going to give you some pointers here that will help us signpost headache. And you know what? Our patients really feel abandoned by us because we don't address the headache, because we don't manage it. We don't really want to listen to our patients. And I think that's the first thing to say is don't ignore my headaches. I think it's okay to say, I'm not a headache doctor, I don't have expertise here, but tell me about your headaches. And we know from the studies that the burden in IIH is driven by the headache symptoms our patients have. It reduces their quality of life. And when we did a priority setting, the patients really placed importance on headache and headache mechanisms being a top priority. So with all these things, we know that headache also not only affects our patient, but if you look in the UK as to how much it costs, in terms of economic and social burden, it costs an awful lot of money and a lot of absent days from work. So it's important to try and tackle. We know that if you put the disease into remission early, So we think about getting on and talking about lifestyle changes. Often those headaches melt away because they don't become chronic. They're not allowed to have, really get going in the head. So putting the disease into remission is absolutely key. We also need to ask about early morning headaches. It's really easy to screen for obstructive sleep apnea in clinic to then signpost that patient to a respiratory physician. In my practice, it's important to get to know the respiratory physicians and present them with the data such like this to say, actually, it's really important. You might think this person just has mild obstructive sleep apnea, but they have horrible headaches. Please, can we think about treating this patient earlier than you would normal patients? We also have to think about what tablets our patients are using. And I was really shocked when we looked at our UK health data, because I really thought that the opiate crisis was not something that was experienced in our country. And I was just really naive when I looked at the data and we showed that our patients with IIH continue to use opiates and simple analgesia when you compare them to migraine and non-migraine controls. So it's important. What it's signposting is we're not treating the headaches effectively, and they're having to use other medicines. And opiates are really, really bad for headaches. Medication overuse headache is in addition to the headache phenotypes that our patients get. And it's because they're overusing simple analgesics or opiates for more than 3 months. So it's really important that we think about signposting some information about medication overuse headache. So we're going to think about putting the disease into remission, referring for obstructive sleep apnea, and then asking our patients, are you using simple painkillers and are they effective? And often my patients will say, no, I take them anyway. It's like, well, you need to stop taking them because they could make your headaches worse. So I think all ophthalmologists should think about informing patients and talking to the family physician. So family doctors, general practitioners are really, really good at treating headache. And so what I usually say in my letter is, the vast majority of headaches in IIH are migraine-like. Please, can the GP treat these migraine-like headaches? Thinking about specific abortive therapies. And we've got some good, nice guidelines that you may want to download that talk about the new treatments from triptans to the newer treatments, GPANs, and just sort of highlighting for those that have headache for more than 15 days a month, they probably need a preventative medication. Please avoid medicines that may exacerbate weight gain or those that can affect mental health, particularly if the patient has a mental health diagnosis. If you've tried at least 3 different classes of medicines and it's not working, you probably need to see a specialist neurologist to help with headache. And then I always say, I've discussed with my patient today, medication overuse headache, and it increases daily headache and stops headache medicines from working, and opiates. And I think I always highlight opiates should not be used for headache. So I think we should, as a group, listen to our patients who have headache, acknowledge that they're really disabling, ask them to keep a headache diary to take to their family doctor, think about their analgesic use. But I always signpost them to some really useful websites where they can then sort of take on the responsibility for their own health journey. So there's a couple of other sides here. I'm just thinking in the last few seconds of the talk, I don't think we should be performing therapeutic lumbar punctures. It seems like something that would be something that you could do and bridge yourself over a gap. But the thing is that the CSF is replaced within 7 hours, so your brain pressure goes back within 7 hours, and the patient can have a variety of horrible symptoms with therapeutic lumbar puncture. We don't perform any surgical intervention for headache. We must consider all the neuroheadache medicines. It might seem simple to send these patients to neurosurgery because then we're passing it down to another specialist, but actually we're better informed about headache and papilledema than some of our surgery colleagues. If you are thinking about doing surgery for headache, we strongly recommend that you do it within a multidisciplinary team environment. So let's put the disease into remission, think about OSA, think about medication overuse headache. And I think I'm getting to nearing the end of my talk. This is a slide that I put up at the start in case anybody wants to have a look at those QR codes. And then we've got a great collection on neuro-ophthalmology in the eye journal. The majority of the articles, there's one on IH, but there's pituitary, OCT, neuroimaging. The majority are free to download, so definitely have a look at that. I love the novel website. I think the cases and the videos are fantastic. And I would like to invite you all to think about coming to Milan in Italy next year for our UNOS meeting. I'd be really happy to take any questions.
Thank you very much, Professor Mollan, for that very, very wonderful talk. So we'll start some questions. So I have one first. Um, how severe is the anemia to cause, papal edema? Because sometimes our hematologists are not really that concerned with hemoglobins at just levels of 10. So usually, what's the anemia severity for this?
Yeah, you're absolutely right. It can be very variable. I mean, I've had somebody walk in with 4.6 after having quite traumatic birth, and those patients, we're not only thinking about an iron transfusion, we're also thinking about a blood transfusion, depending on what's going on. So there's patients that coast at about 10. I do think it's, trying to say to the hematologist, look, they've got really bad papilledema. If we reverse this, I can get rid of the papilledema soon. And so it's just about those conversations. It's very variable. And there's only a couple of studies on anemia and papilledema. And I would really encourage people to put their cases together so that we could really work out at what level does somebody start to develop raised ICP and what factors are involved in terms of their iron count, etc.
Okay. I think Rissel has some more questions from the chat.
Hi, Professor Mollan. There are a few questions on the chat box by Dr. France Cruz. She said that she trained under Dr. Prem and Dr. Neil, where they did a lot of optic nerve fenestration for fulminant IIH. And her question has always been, how soon do you expect papal edema to show improvement and complete resolution after shunting?
Oh no, so that's a great shout out actually. Optic nerve sheath fenestration in the right hands can do incredibly well. I think the literature on optic nerve sheath fenestration is a bit unfair because they often have a delay to get their surgery, not in the hands of obviously Dr. Miller and Dr. Subramanian, who are there on hand and actually do the surgery themselves. But if you have to pass it over to an orbital surgeon, you need to impress upon them. They can't put it on the list next week or the week after. They really need to get on and do the optic nerve sheath fenestration. And of course, if you do an optic nerve sheath fenestration, it doesn't stop you that if you're having ongoing problems, then either doing a shunt or a stent. In the UK, we only have really one centre in Sheffield that does optic nerve sheath fenestration because we've lost those skills. And all the randomized controlled trials are really going towards stenting because I think that's kind of the new kid on the block. I think I can only really speak for shunts and stents in terms of resolution of papilledema. When we looked at all our patients and we published in the AJO, it looks as though within 24 hours, you lose about 20% of your papilledema. By about 6 weeks, you're nearly completely resolved. And by 3 months, you're completely resolved. So the ICP for stent and shunt comes down very quickly. And I often, because the discs are really horrible on OCT, I often move the retinal nerve fiber layer down to the basement membrane to take a total retinal thickness. And that shows me if somebody on a Wednesday afternoon has a shunt and I see them Thursday morning, actually the shunt's working. You can really see it nicely. I can see Marianne smiling, remembering clinic. Yeah. So you should see it very, very quickly. And I would encourage anybody that if somebody goes for surgery, that you do see them promptly afterwards to make sure there's no problems with the shunt or the stent.
Another question from Dr. France Cruz. She would love to hear your opinion on the risk of NAION in patients using GLP-1 RA.
Lovely. So this is a hot topic. So last year, the group in Boston, so Hathaway and Rizzo and colleagues presented that they had noticed that patients that were on a GLP-1 receptor agonist, such as semaglutide, seemed to have a higher risk of having an ischemic optic neuropathy. Now, there's been many studies that have come out, mainly looking at large pharmacovigilance data, so big sort of Medicare data sets, the global TriNex, and some support the association of using a GLP-1 receptor agonist with ischemic optic neuropathy. The Danish and Norwegian groups have also looked to see, and they, in their hands, they feel that the chances of having an ischemic optic neuropathy, when you control for the other typical comorbidities of living with type 2 diabetes, etc., and hypertension, does appear to have an increased risk. Now, the numbers of our patients having ischemic optic neuropathy are very, very small. And there's a lot of issues around the types of studies. So one of the things that was very useful from the Boston study was they made sure the patients had been seen in neuro-ophthalmology clinic. And so the coding of ischemic optic neuropathy was accurate. In some of those larger studies, they're not able to determine that the patient actually has ischemic optic neuropathy. And a lot of them have just used visual impairment. And so I think this is an emerging story. And as we go through the next sort of 12 months, we're going to find more out about this incredibly rare possible association with using these medicines. And it's not only restricted to semaglutide, so tirzepatide as well has been shown more recently to be involved, but also some of the other GLP-1 receptor agonists. I think the difficulty is if you have a patient who is on these drugs, because most of our patients that have non-arteritic either have type 2 diabetes and live with obesity, or just live with obesity on those drugs, those are the risk factors for a non-arteritic anterior ischemic optic neuropathy. So it's about talking to their endocrinologist or their family doctor and saying, is it at the level that we need to switch the medicine, we need to change the medicine, or is it at the level where actually that's not possible? So I think it's on an individual level at the minute, and that's still the guidance from the American Academy of Ophthalmology and the North American Neuro-Ophthalmology Society in their joint statement, sort of thinking about that individual, getting all the doctors in the room that are kind of looking after that patient and deciding whether that patient needs to move off onto a different medicine.
Okay. What are your thoughts, Professor Mollan, regarding the best weight loss management for our patients with IIH, which can be sustained? Is it, by bariatric surgery that, it's already there?
I think it's really important because it is about sustained weight management. And so bariatric surgery isn't for everyone, but for a lot of patients, it does suit them. And hopefully we've already published an abstract, but hopefully our data will be coming really soon. Our 5-year results of the weight trial got delayed a little bit by COVID. So actually they're 7.5-year results, which is actually even better because it's a longer duration. And that trend that you saw with the weight loss, but also the ICP, tracks all the way out. So I think it shows us that it's effective in the long term. It's also cost effective, and the cost effectiveness increases every year following the surgery. I think the issue with the GLP-1 receptor agonist is that worry that those patients need to be sort of on those medicines for life. And I think we're working our way through that as to what that means and how cost effective that would be. But certainly we need to support patients. It's a bit, we always liken it to blood pressure. If somebody has a blood pressure problem, you just don't start a beta blocker for 6 months and then take them off it. The blood pressure comes back. And it's the same with obesity. It's a chronic metabolic disease. So long-term solutions are really, really very important. Yeah.
Okay. There's a question from Dr. Jian. Sorry, where is it? Okay. Are there any key differences in the diagnosis and management of pediatric versus adult IIH?
I think that's really important to highlight. I don't typically see children. My practice is adults, but what I do know from my pediatric colleagues is that disease our children get is very different to the adult disease. So before the age of puberty, you have the same difference between male and female. They tend to not live with obesity. And from what I've heard, I think for some kids, they really progress quite rapidly to have problems with the vision. So I do think it's a different disease. I think once they get into adolescence and they go through puberty, often it's associated with weight gain. So those patients sort of that have gone through puberty, 13 and above, maybe 12 and above, tend to be a bit more like the adult disease.
All right.
Professor Mollan, there's another question. Do you have any helpful diagnostic clues on the pattern or symptoms of cranial nerve 6 palsy in patients with idiopathic intracranial hypertension without papillary edema?
So this is really important, and I think it's an area of focus to talk about IIH without papilledema. So we're not talking about somebody that had papilledema in the past. We're talking about somebody who's never had papilledema, in whom we suspect has raised brain pressure. Now, this is really difficult to diagnose because these patients would go with their headaches to the neurology doctor. And not everybody with a headache obviously gets a lumbar puncture or gets investigated for raised intracranial pressure if they don't have papilledema. And so there's some groups, some big groups in Italy that have done a lot of studies of IIH WOP. And in our books, it's incredibly rare. And I've worked a very long time with our headache service. And actually, I only have a few patients in whom we've diagnosed IIH WOP. And they don't have just small amounts of raised ICP. You know, they have a good going 54, 62 opening pressure. So really high in the absence of papilledema. They may have neuroimaging signs. I use the Friedman criteria for that to say if you have a 6th nerve palsy, you get a definite diagnosis of IIH WOP. If you don't have a 6th nerve palsy or a bilateral 6th nerve palsy, you get a probable. And I think we're thinking about how we can distinguish these patients. And I go back to my comment about MRI ICP protocols. This is still in the research arena, but at some point it will come through to clinical practice where we're able to do a specific protocol to estimate what the kind of velocity is of the CSF moving through the various foramina. So I think that will help IIH WOP. The other thing that I would like to sort of float, and it's something that myself and 2 neurology colleagues will be publishing in the JNO soon, is thinking about, we think about normal pressure hydrocephalus. So that group of patients has a normal ICP, but they can be really sick in terms of their brain CSF dynamics. And we just wonder whether IIH WOP may be a condition where you get normal pressure, but the actual amplitude of the wave is pathological. And that would fit in with other conditions of MPH and traumatic brain injury as well, where the amplitude is more important. And we've only really started to think about this because of the telemetric monitoring and obviously our shunt monitoring in some of our patients. So, we talk a little bit about the bony canal, we talk a little bit about the anatomy of the nerve not developing papilledema. But what if it is normal pressure, but it's just they have abnormal intracranial pressure waves that's causing the morbidity?
So do you also shunt these IIH WOP patients? Let's say they have the 50s, 60 pressure.
So I think this is a really good point. Like, how do we manage it? So if we have patients with IIH and they have a really high ICP, we do think about giving them some acetazolamide, but we are also all about the lifestyle. So if we can modify the lifestyle and use normal medicines, I don't think we should be directly going towards surgical management of IIH WOP. I think we need to be taking the sort of learnings from IIH across to IIH WOP. And we may not be right. The phenotype of the patient may be different, the underlying metabolic disease. We just don't know because we think IIH WOP is actually particularly rare or it goes undiagnosed in headache clinic.
So one Oh, okay. Question from Dr. Karen Reyes. What is your experience in IIH in patients who do not fit the typical phenotype, particularly those who are not significantly obese or even almost normal BMI? Do you find their disease course or clinical response different?
So it's really interesting because as we've grown through our practice, we've really recognized the association with venous outflow. And so a lot of my patients that don't fit the typical phenotype, in fact, we looked at it and it was about 10% of my patients have a normal body mass index. And so we would look a little bit more critically in terms of the venography and if they have a stenosis and whether that is impacting on the development of their sort of IH syndrome. But we also go back to that whole thing, just making sure we've checked their drug history. Do they have any systemic associations? A lot of patients on dialysis, we've got a big dialysis unit here in Birmingham. I have people with normal weight on dialysis that end up with a IIH type picture. It doesn't necessarily change my management in terms of the ICP, and often those patients need, I talked about the dose of acetazolamide. Some of my patients on dialysis need very, very little acetazolamide. Obviously, you check with the renal physicians when you're going to use what medicine, but they need very little to reverse the condition going on. So yeah, I totally recognize there's a group. But the other thing I would say is that when we looked at in the UK, we really find the diagnosis of IH took off at a BMI of about 28. So sometimes in our minds, we think of IIH as people living with significant obesity, but there may be people that nowadays, because of our changing population, where we don't actually consider them to be living with being overweight or living with obesity, but actually they do fit the phenotype.
Okay. One last question. Okay. Um, how about male and IIH? Because I remember Tim Matthews told me that it's almost non-existent for males and IIH. But there are some people who do have it. But considering that's the thought, um, is do we also have a knee-jerk reaction regarding males and diagnosing them with IIH similar to obese females?
I think that's really important because that is what's changed in the last 10 years. When I look to my colleagues at Emory, and we've done some work with them, they had a much higher proportion of diagnosing males with IIH. And I think it's because the tip of the iceberg with what's happened with living with obesity around the world is they had a high proportion of males living with obesity compared to us in the UK. But actually in the last 3 to 4 years, my clinic has started to see men who live with obesity and particularly have a temporal relationship to putting on weight and then being diagnosed with IIH. What we postulate when we think about the hormones, so we think hormonally androgens are driving IIH in women. We've noted they have high testosterone in their serum and their CSF that resolves on having weight management and putting the disease into remission. And we kind of postulate that men probably don't have high testosterone. They actually have low testosterone within this. So it's the sexually dimorphic action of androgens that happens across lots of different endocrine diseases. So I think it would be interesting in the future to think about doing a study with men and characterizing their systemic metabolic condition and see whether we're right as to whether it's low testosterone that's actually driving their raised ICP.
I have one question, Prof. Mollan. For example, you have a patient that's currently on isotretinoin treatment for acne, and actually she doesn't have any symptom, or this patient doesn't have any IH symptoms. Do you actually tell the patient to stop the isotretinoin or go back to their dermatologist? What would you usually say to
So
the
that it's a
patient?
really important question because teenagers that live with acne, it can be really significantly debilitating. And so what I tend to do is I talk about when did you start the medicine. So if they've been on the medicine for 2 years, and then there's other risk factors in terms of maybe they've had an increase in their body weight more recently, you could surmise that actually the isotretinoin is not causative. But if it's happened, within the last 12 weeks, I would go back to the dermatologist. I think you've got to take the level of papilledema. If it's crashing papilledema, that's different. But if you just got moderate papilledema, you've got time to lift the phone, speak to the dermatologist and say, right, what level of drug are you on? Can we back off it? Can we reduce it? Because I know for some, and I've had conversations with some teenagers in terms of, they just don't want to stop the medicine because it has been so transformative in terms of their skin condition. And so it's just about working out, is there an acceptable dose that keeps the eye safe, but allows the person to be on that medicine? Or are there other ways of treating it? So maybe they don't have oral, they go on topical. What's been their route? Have they tried all the other sort of acne medicines? But I think what the question highlights is throughout all those sort of secondary causes of raised ICP is there's so many different people we need to talk to. And I think as neuro-ophthalmologists, we're quite good at picking up the phone and finding people in the hospital. But if you're working, say, as a lone ophthalmologist somewhere, it can feel quite hard to pick up a phone to somebody and say, can you help me with this? Where is it? So I think that's a lot of what neuro-ophthalmology does. But get in contact with the other physician.
Another question from Dr. Franz. How do you answer their question that they've always been obese? How could they develop IIH now?
I think that's really interesting because I think I definitely recognize a group of my patients that haven't necessarily had precipitous weight gain in the last 12 weeks. I certainly have people living with significant obesity that suddenly seem to develop the symptoms, and it may go back to that asymptomatic group. When we really drill down our asymptomatic group, below 10% of patients coming to my clinic were asymptomatic. If we followed them for 5 years, they then slowly became symptomatic, and only about 5% remained truly asymptomatic. So I think the challenge is the sensitive discussion about weight management and living with obesity. And some of my patients, we sort of say, we recognize that living with obesity is the biggest risk factor for this condition. Is it something you want to talk about today? And some of my patients just say no. And I say, well, is it okay if I bring it up at the next visit? And I think it's because they've rushed into hospital, it's been incredibly stressful, and then they feel like they're being blamed for the condition that they have. And there's no great way to start a sensitive conversation except signpost it with them, and then kind of explore which other healthcare professionals can we bring in to help. Because as ophthalmologists, we don't have any training in weight management. So we need to get some friends to help.
Okay. So we missed one question. This is the promise. This is the last question. Okay. This is from Dr. Janice Ferrer. In patients with IIH-WOP, what would be the most beneficial or best diagnostic test that we can request to support our diagnosis?
I think the diagnostic test there is a lumbar puncture opening pressure with contents, really. But look really carefully at those OCTs as well. I think I know about all those neuroimaging signs, but it depends on your MRI protocol. Like when my colleagues in Emory were going on about fluid in Dorello's canal, I was like, we don't even scan that far down to be able to use that as a sort of diagnostic additional sign to other things. So it's really the lumbar puncture opening pressure.
Okay. Thank you very much, Professor Mollan, for this very interesting and very interactive question and answer portion. Okay, so we would like to present a virtual certificate for you.
Thank you.
Okay, so this certificate of appreciation is awarded to Professor Susan Mollan for imparting her expertise during the Neuro-Ophthalmology webinar series for the lecture Idiopathic Intracranial Hypertension Guidelines, given this 13th day of July, 2025, signed by yours truly and our president, Dr. Franz Marie Cruz.
Thank you very much.
Thank you. Okay. All right, so that wraps up today's session. Thank you all for joining us and for your continued commitment to advancing care in neuro-ophthalmology. We hope today's discussion on IIH offered meaningful clinical insights and perhaps even raised new questions worth exploring further. A special thank you to our speaker, Professor Mollan, for sharing her expertise, and to each of you for your thoughtful engagement and dialogue. If you found this session valuable, we encourage you to share it with your colleagues and trainees in neurology, ophthalmology, and beyond. And don't forget to register for our next webinar series covering heavy eye syndrome. So thank you again for being part of this community and for the work you do to improve patient outcomes in this uniquely complex field. Until next time, take care and stay connected. Thank you, everyone.